Hi there, good evening. I wanted to thank you all for joining me this evening. My name is Leslie Garrett. I am the Division Chief of G1 Oncology at Beth Israel Deaconess Medical Center in Boston. Tonight, I wanted to talk to you guys about surveillance and survivorship, life after gynecologic cancer treatment. Obviously, this is a huge topic. Given all the various cancers we treat of the gynecologic tract, as well as the number of sort of systems it affects in women, and either during their diagnosis and treatment or afterward. But so what I've chosen to do tonight is just kind of pick some high yield topics to review with you guys. I sort of took a lot of what I cover tonight from emails that I've gotten over the years from various either primary cares or gynecologists who have helped me to care for these women through their journey with gynecologic cancers. There we go. So the objectives of tonight is to review some of the post-treatment surveillance recommendations for patients with a history of gynecologic cancers. We're not going to have time in this 45 minutes or so to discuss each individual gynecologic cancer, but we'll kind of hit the general principles of surveillance, as well as get into some of the granular for endometrial and cervical cancer tonight. We're going to discuss some of the rationale behind the use or non-use of different diagnostic testing, such as tumor markers or other labs and radiology tests. And then we'll finish the second half of the talk. We'll sort of shift and focus more on some of the survivorship issues that face patients as well as the providers caring for these women. So I'm sure you guys have seen this slide a bunch of times, but basically, you know, in 2023, gynecologic malignancies are expected to afflict approximately 114,000 women in the United States. Gynecologic cancers account for about 12% of all new cancer cases in women and about 15% of all female cancer survivors. And so if you look sort of at this top of the estimated new cases as well as the estimated deaths, I really want to point out sort of both uterus and cervix, because this is where you see sort of the biggest discrepancy in sort of the amount of new cases that we're detecting. And then, you know, obviously the amount of deaths annually, which leave a large portion of women, thankfully, surviving their endometrial or uterine cancer diagnosis. This is unlike ovary, where unfortunately the amount of deaths is closer to the amount of new cases. And then cervix, again, due to early detection and early stage of diagnosis, we are seeing fewer deaths estimated each year, with more and more long-term survivors. So with the growing number of women who are being diagnosed with GYN cancers and surviving, we've tried to come up with cost-effective ways in order to screen for surveillance and as well as detect early recurrence where we think it can make a difference. But despite lots of expert opinion, there's actually little data sort of driven recommendations, and therefore what we're often left with is, again, expert opinions based on very little data. And so again, what that leads to is a lot of confusion, a lot of people doing it kind of, you know, different ways in terms of, oh, this is what, you know, they're doing out in the community versus at BI versus over at Dana-Farber. You know, there's very, very large variations in who's getting CAT scans, how frequently they're doing CAT scans, how often should you see these patients. What tests should you do? And that leads to a lot of confusions. And so I'll get, on a daily basis questions. I saw a patient who underwent a radical hysterectomy, in 2007 for a cervical cancer. And she's been getting annual pap smears. Can I space them out to Q3, Q5? When do I stop doing them? 41-year-old patient diagnosed with, early stage ovarian cancer, underwent a BSO, and the GYN started her on hormone replacement therapy. Is that okay? Or a 70-year-old who underwent a hysterectomy for early stage endometrial cancer. Now Gyn-Onc wants me to see her. What should I do when I see her? What if I miss something? Does she need a pap smear? What do I do if I see something suspicious? So all of these questions, hopefully after tonight's talk, we'll have a little bit of a better understanding, and sort of what is the data behind what we do. So the role of surveillance is obviously trying to detect recurrence when it happens. Also keeping an eye on what is cost effective in a world where the cost of care is escalating and financial toxicity is impacting our patients and their families. We want to decrease the morbidity of what our surveillance tests are doing. So are we ordering tests that lead to more invasive procedures, but aren't really impacting overall survival or progression-free survival? And then if we do detect recurrence, are there things we can do about it? So I think that's sort of one of the huge take homes that I hope you all will get after today's talks is that, what I hear from my patients and what, intuitively makes sense is, I want you to keep a close eye on it. I don't want to miss it. I want to find that recurrence the minute it happens, because if we catch it early, I'll live longer. And while certainly that is a very sort of proven and accurate statement when it comes to the initial diagnosis, unfortunately, in a lot of our diseases, it's not necessarily the truth. And early detection, especially an asymptomatic recurrence, can often lead to starting treatment earlier. Those treatments have side effects, and that can impact quality of life, cost, and then ultimately not change the needle in terms of how long these women are living. And so we really should be directing our surveillance at finding those recurrences that are amenable to curative or significant palliative treatment. So this was from a review that was done in 2011 and then updated in 2017. The role of surveillance is based on the concept that the detection of recurrence in the asymptomatic stage results in a better therapeutic, options and outcomes. And again, this isn't always the case. And so that's really where our guidelines have tried to sort out, who's getting routine CAT scans and who's not, and how we make that decision. So how good are we? How good is what we are doing at detecting recurrences? And so there's lots of different methods, from the physical exam to the pap smear to the chest x-ray and CA-125 levels for various cancers. And as you can see, when you look at things like the pap smear, not a lot of evidence here that these are effective ways of finding recurrences. Same with chest x-rays. So yes, you can do them. They're cost effective. They're not, they're sort of easier to do, but are they really actually helping us find these cancers earlier? CA-125 levels, again, when we look at ovarian cancer, this is a very common tool that we use. The cost of getting these levels are is not insignificant, but again, it has probably more of a role in ovarian cancer than what we see in endometrial cancer. So we're going to look at some of these modalities a little closer, in specifically focusing a little bit on endometrial cancer as well as cervical cancers. Again, this is what's making up a great, the largest proportion of our cancer survivors and women who you are likely to hopefully meet and take care of for a long time. So, I've mentioned cost. So many of you may have heard of the Choosing Wisely campaign, which was an initiative done. And again, this was across disciplines, but they really sort of looked at expert associations, ACOG, SGO, and sort of said, okay, well, let's pick some of the areas where we can make a difference in, looking at some tests that are being done reflexively that really don't make a whole lot of sense. There isn't a lot of data, and there is significant cost in these procedures. And so we're going to look at these, but these are really important. Choosewisely.org if you've never seen them, but these are the sort of top 4 that really everybody who is taking care of women with a history of gynecologic cancers should be following. So the first is, don't screen low risk women with CA-125 and ultrasound for ovarian cancer. So again, this isn't part of surveillance or survivorship, but again, is an important, and I'll plug that whenever I can get a chance. Don't perform pap smear tests for surveillance in women with a history of endometrial cancer. And again, we'll talk a little bit more about that. Don't perform colposcopy in patients treated for cervical cancer with pap tests of low-grade squamous intraepithelial lesions or less. And again, we'll dive a little bit more into that. And then avoid the routine imaging for cancer surveillance in women with gynecologic cancer, specifically ovarian, endometrial, cervical, vulvar, and vaginal cancers. So again, they're out there. This is sort of stamp of approval by our professional groups, and really is something that should be followed. But if you actually look at this and you were to look at the number of people who follow these, the numbers are embarrassingly low. So we're going to look at endometrial cancer. It's the most common GYN cancer. It's the 4th most common cancer in women. So this is, again, you guys are, if you're generalists here tonight, these are the patients that you're seeing in your office. They present with bleeding, and therefore, since symptoms are common, 83% of these patients are diagnosed at an early stage. And the 5-year survival for early stage disease is excellent, exceeding 95% for, again, stage 1 disease, and 83% for all stages. These are curable cancers. Again, this is the greatest proportion of our women who hopefully are living normal life expectancies despite their cancer diagnosis. However, recurrence rates are still not negligible, and even in early stage disease, we can see recurrences from 2 to 15%. Based on histology, lymphovascular space invasion, some of the other things that we see on our final pathology reports that help us to come up with an idea of prognosis. And then obviously for later stages, stage 3 or high-grade histologies, we can see recurrence in up to 50%. And the most important thing to know about endometrial cancer is that about 1/3 of recurrences are local, meaning they're going to be an isolated recurrence right where as I tell patients, right where the uterus used to live. So the top of the vagina is again, is a very common place. And when that is the only place where the cancer has recurred, these have a very good chance of cure. And so here is a perfect example of where catching the recurrence early matters, because there is an opportunity for curative intent therapy. So most recurrences will happen in the first 3 years, and most of them are diagnosed on physical exam and with review of symptoms alone, detecting over 80% of our recurrence and of patients' recurrences. And so again, ask about symptoms, things, pelvic pain, bleeding, bloating, pressure. What I tell patients is anything that is a change in your, in how you feel, and it doesn't go away after a week. And the other thing I tell patients often is, you live with your body 365 days a year. I might be seeing you every 3 to 6 months. These visits are here to educate you on what to look for, and knowing that if at any point you are concerned, you let somebody know. Trust your instinct. But if patients come into my office saying, I feel great, I have no symptoms, I have no worries, it is very, very, very rare that I will find something on her exam. However, if they come in and say, I've seen a couple episodes of spotting, I've had, some lower extremity edema that I didn't have before. These are all things that, I may find something on their physical exam. The key to our physical exam is the pelvic exam. So, in a lot of places where gynecologic oncologists are doing the surgery, they're doing the chemotherapy, they're seeing the patients for surveillance, it's a no-brainer. Pelvic exams are very much a part of surveillance. A lot of patients who return to the community for their adjuvant treatment after are not seeing a gynecologist. And I try to stress the importance of pelvic exams to all of my patients. They kind of, everyone will look at me and say, well, there's nothing left. What are you looking at? I'm sure you guys have all heard this, but it is so important. And this is why, because this is where we're going to pick up the recurrence. A CT scan is going to miss it, an MRI is going to miss it, but lo and behold, direct visualization and palpation, a good rectovaginal exam. These are the things that are going to find the cancers, and explaining that to your patients, educating your patients so that they can advocate and speak up when they think something isn't right. So again, we talked about don't perform pap smears for surveillance for women with a history of endometrial cancer. So, back when I was a medical student, everyone was getting pap smears when they came in for their endometrial cancer surveillance visits. This was, I'm going to pap the top of the vagina. This is going to find the cancer. And what they found is that, yes, it can find the cancer, but very rarely is it finding the cancer that you can't see, right? So really, yes, you put a speculum in, you see a friable bleeding lesion and you pap it, your pap smear is going to be abnormal and probably say, hey, adenocarcinoma. But you would have biopsied that, right? That's a pap smear as a screening test. They do not pick up endometrial cancer recurrences. They should not be done routinely. Again, there's no clinical benefit. It is not additional to a visual inspection of the vagina, and as well as a good vaginal exam and rectovaginal exam. And the cost is not insignificant, with vaginal cytology at each visit estimated to cost up to over $27,000 per case detected. So what about CA-125? So CA-125, you guys instantly think about ovarian cancer, and yes, there is a role for CA-125 in ovarian cancer, and trying to look for response to therapy, and also detecting recurrences. But in endometrial cancer, it's not as specific. So pre-treatment CA-125s can be elevated in over 50% of patients with either high stage or high grade endometrial cancer. And so, it might be useful, again, in detecting recurrences of high-grade serous endometrial cancers. And so if you do a preoperative biopsy and you get a grade 1 endometrioid cancer, I probably would not do a CA-125, nor would I continue to follow CA-125s. But in the patient with a high-grade serous, often a CA-125 preoperatively can be helpful, and also can be a marker postoperatively to look for response to disease, as well as picking up recurrences. But unfortunately, what ends up happening is you sort of say, okay, well, maybe it's helpful. And because it is sort of only helpful in very specific circumstances, then it gets translated, and everyone who has endometrial cancer should have a CA-125. And the utility, especially in low-risk disease, which makes up a great proportion of patients, the utility is pretty negligible. And again, false elevations, which we see, fatty liver disease, cirrhosis, lung disease, other things that other gynecologic benign conditions can that also lead to a lot of distress. And so I along with others have proposed that this should not routinely be done as part of a screening for endometrial cancer, or surveillance rather. And so how about imaging? So again, avoid routine imaging for cancer surveillance. So, this is something that has been sort of ingrained as me, has been sort of ingrained in my brain since I was a fellow, is what I'm trying to say. That, doing routine imaging on asymptomatic patients is not cost effective. And not only is it a cost to the system, but it's a cost to the patient. And so patients will bring this up. I need a CT scan. You need to make sure that you're finding my endometrial cancer. And probably a lot of offices, it's just an easier thing to do. Medical oncologists who aren't doing pelvic exams, and they're good intention. They don't want to miss things. They don't want to miss a recurrence, and they don't have the ability to do a good pelvic exam. They may fall back on radiology, and I have to say that a lot of patients don't know, they understand why it's being done. It makes sense to them, but it does take, a good 10-minute discussion with my patients to really review that, if you come in and tell me you feel great, you're not having pain, you're not having bowel or bladder symptoms, you're not having digestive issues or vaginal bleeding, or I'm not going to find anything on your CAT scan, right? Except I might find things that aren't related, right? And now I have to go down the rabbit hole of, oh gosh, there's a cyst on your liver and radiology wants a MRI. So now I'm going to get an MRI, and then the MRI is going to want a follow-up MRI, all for something that, the patient was probably born with. So, once I have found my experience that once I take the time to sort of explain this to patients, that, I'm not going to tell them that they're never going to get a CT scan again. They likely will, because they likely will have something that will concern them, or a symptom, or a finding on physical exam. And in that case, I'm going to be the first person to put the order in for a CAT scan, but I'm not just going to do it reflexively at certain intervals for the first 2 years and then the other intervals, because there's no data behind it. It very rarely will pick up an asymptomatic recurrence. And again, survival is not impacted in most of these cancers, where, especially in endometrial cancer, whose recurrence is detected on imaging versus exam. So if studies have looked at, an asymptomatic patients, if we find it, or if just looking at recurrences, whether it's asymptomatic or not, whether we find that recurrence based on imaging or exam, the outcome, the survival is the same. PET CT, lots of patients will ask about it. I have cancer, should I be getting a PET CT? They'll ask at diagnosis, they'll ask for surveillance. It is a very expensive tool. It is not well studied. And while lots of reports written by radiologists that will report its accuracy, even in asymptomatic patients, again, it shouldn't be used routinely. However, despite all of this, the lack of data, the lack of changes in overall survival in detecting asymptomatic recurrences with routine imaging, its routine use is on the rise, and we see it very, very frequently in patients, again, who, especially my patients who end up leaving or are going out to get their adjuvant treatment with different providers. So this is a perfect example. This patient does exist. This is one of my patients. She's a 76-year-old. She was diagnosed with a stage 1B grade 1 endometrioid adenocarcinoma of the endometrium in 2021. Due to the depth of invasion, vaginal brachytherapy was recommended, and she received that with our radiation oncologist, finished in February of 2022. Based on, again, NCCN guidelines that say that surveillance for these low intermediate risk patients should be every 3 months for the first 2 years, and then every 6 months for 3 years after. She was being seen alternating with both the G1 oncologist as well as the radiation oncologist, and had several surveillance visits where she was asymptomatic. Her exam was unremarkable, but at her most recent routine visit, she sort of says, well, I've had a handful of episodes of vaginal bleeding, but it's every time I take ibuprofen. And then, and I've had some cramping, but I think down in my pelvis, but I think it's my reflux. And I'm a little more tired, but, I'm moving to South Carolina and I'm doing a lot of packing and I'm really stressed out. So I think that's why. And, and every now and then my bowels are. So on review of symptoms, she pretty much has a positive review of system in every single thing you could think of that would make me concerned about recurrence. Though in this patient's mind, despite being counseled at every one of her surveillance visits on the symptoms that should be concerning, she's somehow figured out how to justify each of these symptoms that she's been having. So we do a physical exam. We don't feel any lymphadenopathy. Her lungs are clear. Her abdomen is soft. There's no palpable masses. But when we put the speculum in, our visualization is limited due to the blood. And when we sort of wipe it away, we see a friable, bleeding, sort of slightly bulging nodule near the introitus at 6 o'clock. Now, I told you, again, third of patients are going to recur in at the vaginal cuff, which is why she got brachytherapy. Because the radiation, again, only treats a few millimeters at the top of the vagina, but this woman had something that was concerning right at the introitus. And so on rectovaginal exam, we can palpate a 1 to 1.5 centimeter nodule. We do a rectal exam. We don't feel any rectal mucosal involvement. And of course, at that visit right then and there, we obtain a biopsy with the Tischler that confirms adenocarcinoma consistent with recurrence of her prior endometrial cancer. And so once we have confirmed recurrence, we then send her for a CAT scan to see if this is the only site, is this just the tip of the iceberg? And actually her CT scan is completely negative, which is good news for her. But again, if this one was not having a pelvic exam, if she was just getting a CT scan and came in with all that, no one was doing a vaginal exam, she would have been sent out saying, oh, your CT scan's clear, no signs of disease, you're all set. I bet your bleeding is from your ibuprofen use. And trust me, we see this all the time. Need to look in the vagina. And so we then do get imaging, of course, and here is actually a picture of her MRI. And again, this is the, the bladder. Obviously, she no longer has a uterus. This is the vagina here. And right here at the introitus, you see this nodule here. And again, this is the vagina. This is gel that our radiologists have put into the vagina and right along the posterior fourchette. Obviously not touching the rectum, but in right here in the fourchette, we see again this 1.5 centimeter recurrence. So the good news is she's going to go to the operating room. She's going to get this resected, and we are treating her with curative intent. She's a very good prognosis despite recurrent disease. So we're going to switch over to cervical cancer. Again, 1,300 new cases a year, which is actually a very small number compared to worldwide. But again, fortunately, of these 1,300, about over 50% are early stage with an over 90% 5-year survival. So again, cervix cancer, another place where we're going to see long-term survivors who will hopefully end up in your office someday for ongoing surveillance. So despite early stages, however, 10 to 20% will recur, and surveillance is important. And again, the success, so with endometrial cancer, we talked about that isolated recurrence caught early. We can make a difference. We can impact survival. With cervical cancer, really our ability to cure recurrence depends primarily on the therapy. So, it almost seems counterintuitive. The patients with the lowest risk for recurrence are those are the ones we should watch the closest, and the ones with the highest risk of recurrence, we should still watch them closely, but unfortunately, our ability to sort of impact long-term survival with our treatments for recurrent disease is very limited. And so most of our treatments in the recurrent setting in patients with high-risk disease who have been already treated with chemotherapy, already treated with radiation, if that patient recurs, our therapies are going to be purely palliative. And so this is the sort of example of, you have an asymptomatic recurrence in someone who has already gotten chemo RT, has already, really their widespread recurrence. Any treatment is going to be palliative. And therefore, what are you palliating if their recurrence is asymptomatic? So, that's, again, where we need to sort of differentiate when we come up with these surveillance plans. Again, most recurrences will happen in the first 2 to 3 years. So with cervical cancer, the presenting symptoms are things like pain, leg pain or lymphedema from sort of nerve involvement or nodal involvement, vaginal bleeding or discharge, urinary symptoms, cough, weight loss, when, if there's recurrence in the lungs, and obviously more widespread is going to lead to more systemic treatments. But still, this, and again, as we saw in endometrial cancer, physical exam accounts for the highest detection rate, much better than cytology, much better than imaging. And again, your physical exam should involve, with these patients, a complete assessment of areas that are susceptible to HPV related diseases, such as the vulva, the vagina, and the anus. So cervical cancer and pap smears. So it is important to distinguish with patients why you're doing pap smears. So in a patient who had early stage disease that was treated with surgery alone, you're doing pap smears of the vaginal cuff. In patients with locally advanced disease where they were treated with primary chemoradiation, these patients still have a cervix, and you're papping the cervix and upper vagina. And again, this is not to detect recurrence because the pap smear is really lousy at it. This is helpful in detecting lower genital tract disease. And therefore, despite the fact that I'm going to see patients every 3 months for the first 2 years, and then every 6 months for 3 years thereafter, I'm not going to do a pap smear at every visit. I'm going to limit it to once a year because, again, radiation will make pap smears abnormal and hard to interpret. There are some who actually advocate for not doing pap smears at all if they've gotten radiation. I tend to do them, but again, we'll only do colposcopy if HSIL or higher. And so again, this is in agreement with the Choosing Wisely campaign that basically says, you know, you get an ASCUS, high risk HPV, pap smear, don't do colposcopy. It's low yield. It's not cost effective. Here, I can guarantee your colposcopy is not going to be adequate. These patients have stenosis of the upper vagina, stenosis of the cervix. The tissues are indurated and difficult. And again, it's a lot of pain and suffering on you as the provider, as well as the patient for very low yield. The role of HPV testing has not been well studied. Obviously, you know, what we know is that the persistence of HPV, obviously, the longer you have it, the higher risk you are. And a lot of these patients, especially immunocompromised patients, will not clear their HPV infection. So again, it emphasizes the importance of screening not just the cervix, but the vagina, the vulva, and the anus for, dysplasias, high-grade dysplasias that can be acted upon to prevent the progression to carcinoma. What do we do for imaging? I can tell you that even at the Beth Israel, it depends. It depends on your doctor. It depends on your how worried they are. While we try not to be emotional and we try not to be, and we try to be data driven. There are some patients who, quote, make us nervous. We worry that we will miss something. We do want to intervene if they happen to be that patient where it's a small central recurrence and there is an opportunity. There's data for isolated pulmonary mets or supraclavicular adenopathy or recurrences that are happening outside of a radiation field that have been salvaged effectively. And so while, again, the general principle is that recurrent metastatic cervical cancer is incurable, our therapies are improving. We are seeing small successes. And, again, there's really no good data that helps us to really guide us in how often we should be doing it. Again, PET-CT we know is really good. It's especially in cervical cancer, and it has even been reported to detect asymptomatic disease, again, amenable to curative intent therapy and improving a 3-year survival to upwards of 86%. Cost analysis models, again, show conflicting results on whether doing routine screening is cost effective. A lot of this is, as numbers are low, it's hard to really pan out who are the patients within cervical cancer as a whole who are benefiting and it is cost effective versus those who aren't. And so if you have a study that is made up of, a lot of high risk patients who, recur metastatically and are incurable, you're going to show that there's really not a cost, that it is not a cost effective strategy. However, if you have low stage patients where again, the recurrence is salvageable. Maybe this is going to make more sense. So again, we try to focus on detecting the recurrent disease that is amenable to treatment and that will result in cure or long-term survival. And so often, this is a thoughtful discussion between the patient, myself, the radiation oncologist, sort of, okay, well, we've done radiation, we've done chemotherapy. She's got a lot of medical comorbidities and is pretty debilitated. You know what? If we do detect recurrence, there isn't a whole lot we're going to be able to offer this woman. And so again, that's the patient where you're not doing routine surveillance. You're really letting her guide you to, her coming in saying, I have a symptom, something's hurting, I'm in pain. And now we want to investigate to see if there is an opportunity to palliate those symptoms. So this is sort of a table in recommendation. So, looking at the first year. So for our endometrial cancer, stage 1, early stage, in the first year, I might see them at 6 months, or often early stage patients who don't require any adjuvant treatment. I often see them for their post-op check and say, hey, you know what, go see your primary gynecologist in 6 months. And, if you've healed well from surgery, she's been able to review your treatment, the pathology. I try to communicate in post-operative notes, especially if I send them back to the referring provider, sort of saying, here's what they need, here are the things you need to educate them about, and obviously any concerns, any questions, I'm always happy and available. And so for the often those low risk patients, after that initial visit, it can be spaced out to either every 6 months for the first 1 to 2 years, but even every once annually, depending on your relationship with the patient, depending on how reliable you think they are. Are there other issues of recovering from surgery, pelvic floor dysfunction that you want to be able to intervene in? Might not want to make them wait a whole year, or are they totally fine? And you feel like they're going to call you if the second they feel their big toe twinge in the wrong way. So I often make a recommendation sort of broadly, and then after the 2-year mark, I think it's pretty safe to, again, in these low risk patients, go to annual exams sort of indefinitely. And I do tell my patients that just like they're going to listen to your heart every year, they should also look at your vulva and examine your vagina and do a pelvic exam every year, which doesn't happen a lot, but I try. In high-risk patients, again, we're sort of tightening that interval. We see those patients every 3 months for the first 2 years. Then we space to 6 months for years 2 to 5, and then we do span it out to annually once they hit the 5-year mark. Again, pap smears yearly for cervical, vulvar, vaginal cancers to screen for lower genital tract neoplasia. Insufficient data to support routine use in these patients. But if you are suspected on either physical exam or by symptoms, then a CT scan or a PET scan can be considered. So that is sort of, obviously there's nuances to all of those guidelines. Again, the important thing to stress is, making sure before you order the test, before you order the scan, that there is a reasonable solution to whatever you may find, and that they're not benign. Even a blood draw, CA-125, can often lead to increased anxiety and distress, and extra testing that is, that could be avoided. So now we're going to switch gears a little bit. quickly to look at survivorship. Again, you guys know a lot of this, but what is survivorship? It focuses on the physical, the emotional, the financial issues that are unique to cancer survivors. It's about finding a care plan, helping to coordinate care between the oncologist and the primary care. Many cancer survivors will experience problem with bowel function, urinary function, sexual function, infertility, early menopause, fatigue, insomnia, neuropathy, lymphedema. These are all very common late-term consequences of the cancer diagnosis and treatment, and obviously mental health and wellness. So we are, the survivorship care plan is something that we have instituted within, and you may have seen these in the medical record. These are typically being done by our awesome nurse practitioner, Kate Nolan, who is doing a lot of the surveillance for our patients, where it's also being done by the radiation oncologist. I think Epic is probably going to make this a little more user-friendly, because I'm sure they'll make it so that you can't, get to the next stage and without filling out this form. But really, this is a way to improve adherence to screening tests, to surveillance paradigms, and also improve communication between the patients, the PCP, and their oncologist, because studies have shown that, patients don't feel that their doctors talk to one another. And the truth is, we probably don't. We're all too busy. We're all doing the best we can. We hope they have access to the medical record, but this is something that has been recommended in order to try to improve communication, and also sort of delineate sort of who's in charge of what, who's in charge of the mammogram, who's in charge of the colonoscopy, who's in charge of doing the pelvic exam and the pap smear, because often I get lots of emails wondering, are you doing it? Am I doing it? Or, and we might tell the patient, but by the time the patient gets to see that doctor, it's already been forgotten. So because of this, lack of evidence-based guidelines involving survivorship and surveillance, the Institute of Medicine released this this sort of guidelines, or sort of to look at, when the patient is going from being a cancer patient to being a cancer survivor, and that transition of care that happens, and trying to identify needs and services, improving communication. So this came out, I forget what year, I think maybe about 10 or 15 years ago, but this is an important document sort of highlighting some of these issues. And then our societies have toolkits, again, trying to empower patients to speak up, to be educated. This is one that's on the SGO website that is very, basically it's aimed at for patients to use, but they'll say, send your doctors to these sites, because they too, can help to improve education and communication around issues that are affecting our cancer survivors. So fatigue is huge. Patients are going to come in, chronic fatigue. It's a very common symptom. It does get better, but it takes a very long time. And so again, a lot of it is managing expectations. I'll tell my patients who've finished chemotherapy, it's very normal that you're still tired. I know it's been 3 months. I know it's been 6 months, but it's going to take a year. You got 6 cycles of chemotherapy. It's going to take, plus surgery, plus maybe radiation. It's going to take at least a year, if not longer. A lot of patients sort of see it as an acceptable outcome, but there are ways that we can help. There are psychosocial interventions. We also know that it can be potentiated by things like depression, distress, anxiety, pain, sleep disturbances, and there are some things we can do about that, such as the use of antidepressants, helping with sleep, using our stimulants to help with concentration, And so this is something that should not just be, well, I had cancer and therefore I'm going to be tired. Distress is another one. Again, anxiety, depression, fear of recurrence. So in a survey of gynecologic cancer patients, over 85% of patients reported, psychological distress. Fear of cancer recurrence, or FCR, is again more common in younger patients, as well as those with lower quality of life, from other things such as depression, financial toxicity, and result in a higher level of distress. And so again, knowing this, that there is support, you need to ask about these things. How are you feeling emotionally? How is this? It's very easy to get sort of, are you bleeding? Are you in pain? Is your bowels working? But, how emotionally are you doing? Because I also have learned that what I see in the office is often very different from what they are in real life. So I might have a patient who's literally shaking on the exam table, but then when I ask her, she goes, oh yeah, when I'm not in the office, I'm totally fine. I barely ever think about my cancer. And maybe they're not telling me the truth, but you need to start the dialogue. You need to ask the questions. There are things, there are resources, and to, again, listen, and to provide some validity. This is normal. It's normal to feel this way. A lot of people feel this way. And, I think one of the most, striking thing I learned being attending was that, when patients go through surgery and then chemotherapy and radiation, their loved ones and caretakers might be like, see them and say, oh, you must be so excited. You're all done. You must be so happy. And that's actually the most common time where depression can hit and patients can crash. Because when they're undergoing treatment, they're being seen all the time. They feel like their doctors are, seeing them every few weeks. They're doing blood tests. They might be doing, physical exams. They're asking them, they're meeting with them. They're being able to, they're preoccupied by wondering about the side effects of certain medications. They don't have time to worry about recurrence because they're too much into the mix. And then all of a sudden the treatment's over and the doctor says, all right, I'll see you in 3 months. And 3 months, the patient looks at you and says, what do you mean 3 months? You've been seeing me every week for, the past 6 months. And now I have to go 3 months before I see you. And that's really hard. And while everyone around them is saying, oh, you must be so excited. Let's have a party. This is where depression can really impact our patients. And so this is, again, something to talk to them about. Likely, I don't need to talk to you guys about the impact on sexual function, body image, the changes to the vagina. I'm going to sort of skim through all of this because I know you guys know about this, but it is there. It is something to address. There are things we can do. Little plug for the Center for Intimate Wellness and Malika. This is huge. Patients, you need to ask about it. A lot of hesitancy because providers don't feel trained in dealing with it, but also the patient doesn't want to bring it up. But this is impacting their quality of life. It is a detriment, and it is, it is something that can last, again, maybe for the rest of their life. And so the last thing I'm going to sort of talk about, because I get a lot of emails about this, is hormone replacement therapy and cancer. And so again, don't have a lot of data, right? We don't have a lot of data for every study that we have that says it's safe. You have another study that says it isn't. A lot of times these are retrospective. They're small numbers. It's really hard to know what the right thing to do is. And, but yet these symptoms are negatively impacting not only quality of life, but long-term survival. Patients are having symptoms. It's affecting their quality of life. And, we know as providers, estrogen is going to help, but is it safe? And, that fear of recurrence balanced with the impact on quality of life. The patients survive their cancer. We want them to live, right? We want them to live a full life and sort of learn to live again after going through such a traumatic diagnosis. And so while there are some specific tumor sites where there is sort of very clear guidelines that HRT should be avoided, in general, the studies say that it's safe. And so where are you guys going to see it? You're going to see it in, again, your low risk endometrial cancers where the patient now has vulvovaginal symptoms and you want to use vaginal estrogen. There's no data that says that using estrogen is going to make their cancer come back. Now, would I give vaginal estrogen to women because I look in their vagina and it looks atrophic, but she's otherwise asymptomatic and it isn't bothering her? I wouldn't. But is a woman having recurrent urinary tract infections and it's, compromising her kidney function, and then yeah, I would, if the urogynecologists want to give her vaginal estrogen, I don't really have data that says it's not. So, again, when we look at estrogen therapy, there is even studies that say that it might even be beneficial. So definitely it doesn't hurt, and maybe that might improve survival from both a cancer survival standpoint, but also, heart disease, things like that, osteoporotic fractures. So estrogen therapy is likely okay. Progestin, however, is needed if the uterus is still present. And so this is, for example, our cervical cancer patients who got chemo RT. And while the cervix sure looks dead and the uterus and the endometrium probably is cooked, there may still be some viable endometrium in there, and you don't want to give that patient unopposed estrogen. So those patients are going on combined HRT. And then also, non-hormonal therapies. And so this was an example. This is, again, an exchange that happened between a patient's medical oncologist and my entire division. This was an email that kind of went out and said, I've got this 40-year-old patient. She underwent a TLH-BSO for endometriosis. Path shows a stage 2B clear cell cancer. She finished her adjuvant chemo. She's miserable with hot flashes, night sweats, and emotional. And her gynecologist started her on estrogen therapy. And I mean, is this okay? And so, she writes an email. This is her G1 onc provider that she's seeing in surveillance, and says, given her disease and that I know it's estrogen receptor positive, I feel this is a contraindication for her to be on HRT, to which the medical oncologist said, well, still, we don't know. And some studies show that maybe it's okay, and it might even improve survival. I think it's okay for her to continue now, and we can periodically reevaluate. Meaning, how bad are the symptoms? Is there an opportunity to wean it off? And so what did we all think? Well, I agree, I would lean against it, but the patient can decide. This article that was quoted is only 150 patients, only 10% are clear cells, so I'm not sure. Also provides some evidence for the lack of harm. And if the patient really wants to use it, and that's her choice. But have you tried the other options, the non-hormonal options first? Another medical oncologist, I agree, patient-centered. I worry less about clear cell carcinoma. Again, we have no data between the different types of ovarian cancer. So, don't feel bad. We still don't know what the right thing to do is. The most important thing is talk to your patients, tell them what we know, what we don't know, and let them decide. Cognitive defects like deficits, rather, not defects, chemo brain, short-term memory loss, decreased attention span and concentration. This is further exacerbated by fatigue and anxiety. There are things like stress management, occupational therapy, our Brain Fit Club. I tend to refer patients there for neuropsychological evaluation and then rehabilitation. This has been shown to be beneficial in our patients. And again, neuropathy, lymphedema, chronic pain, there are things we can do. These are important things to bring up with our patients. And again, using a multidisciplinary approach, getting the lymphedema patients seen by our lymphedema specialists, compression stockings, peripheral neuropathy, sometimes having them see neurology. There's sort of inconsistent data about the effectiveness of things like gabapentin, but acupuncture has been shown to be. So just, again, acknowledging it, monitoring it, and trying different things to try to improve that. And then again, chronic pain is very frequent. And then don't forget about the rest of them. So, again, they survived their cancer. That cardiovascular in patients with early stage disease, cardiovascular disease remains the leading cause of death. And so remembering to counsel them about weight loss, diet, exercise, smoking cessation. All of these are much less likely to be emphasized in cancer survivors. And don't forget about screening for other cancers. In conclusion, there's a lot of uncertainty. There's a lot of debate. A lot of this is patient-centered. Reach out to us. We're going to need you. Hopefully, we will continue making advances in the treatment of these cancers, and we're going to see that our population of survivors is just going to get bigger and bigger. And we want our patients to maintain relationships with the gynecologist. This is important in terms of their well-being, and you guys are a whole lot better at remembering their mammograms and their colonoscopies and the rest of them and their other comorbidities than we are. We will continue to strive as G1 oncologists to improve our communication and things like the survivorship care plan. I'm hoping this is going to be built into our Epic, and so that it will be a reference for patients, for providers, and will improve communication between our patients and again, and their providers. Thanks. I think I went a little over. I apologize. And if you're still hanging in there, thank you. And I'm happy to take any questions. If anyone has any, they can put it into the Q&A. And if not, that's okay too. Sorry about flying through the last half. I always seem to do that. I get caught up in the beginning, but hopefully you guys found this useful. Again, thank you for helping us to take care of our patients and your referrals, and always feel free to reach out. Oh, we have a question. Ha, that's not a question. Thankful, Laura Bookman. Thanks, Dr. Garrett. You're welcome, Laura. Happy, again, happy to answer any questions along the way for any of your patients.